Um, I always come up with things to talk about based on things that happen to me in the practice. And what I found was no one likes to talk about death. I've been practicing for 35 years, and in the last 5 years, I've seen a change in what I'll call stages of death. The way I addressed today was, who's taking care of your end-of-life care? And if your answer is, I don't know, then figure it out today. If you have somebody that you already talked to about end of life, then make sure they know what you want. Because what happened, I'll go back to this in a minute. What happened to me, I would say over the 35 years, 50% of my patients were over 70. I spent 15 years, I won't mention the name, but I was medical director of 4 different nursing homes. And I was medical director of a hospice palliative care. And to be honest, I've been practicing, like I said, 35 years, and I'm independent, so I always looked at things to do. So I ran a home care company the first 20 years that I was in practice. When I say ran it, I was the medical director, okay? I didn't believe in hospice. I didn't think that hospice was necessary, because when I first started practice, you stayed in the hospital. You know, we would admit you to the hospital, and you wouldn't leave the hospital till you were well to go home. Well, all that changed, and it went into nursing homes. So then it became skilled nursing in the nursing homes. So I became the medical director at multiple nursing homes to manage those cases in the hospital, or excuse me, from the hospital into the nursing homes. And so what I witnessed in that time period, we managed it. You know, you handled whatever it happened to be. And then managed care came. And everything got classified. Or let's say a file cabinet. Think of a file cabinet. As a primary care doctor in internal medicine, I manage everything for the patient. And then based on the disease process, let's say they have a stroke, I would get a neurologist to help me manage the brain, what happened from the stroke. If they had a heart attack, I would get a cardiologist to help me manage their heart. That's how we practice. When managed care came, the insurance company told you how that was going to work. And that was the start of hospice and home care. Everybody follow me? When I first started in practice, there was no such thing as hospice or home care. You stayed in the hospital until you were well. And then if you weren't well enough to go home, they didn't call it skilled nursing. These were actually nursing homes, and you went to different places. One of the ones years ago, now I think that, I forget which one of the nurses, I think St. Barnabas has it now. But long story short, I spent a lot of time at St. John's Hospital on the north side. And they had drug and alcohol, they had psych unit, they had everything you needed for the community, but they had a place called Valencia Woods, which was a 200-bed nursing home. And so if you were in the hospital with a stroke and you weren't well enough to go home, you went out to the nursing home until you got well. And oh, by the way, Medicare paid for all that. Okay, so everybody follow me? So I've witnessed all that change. And I didn't think that hospice, when I say necessary, we managed everything. But once managed care came, what they did was your insurance was paid by your employer, or if you were already on Medicare, It was based on your dollars and cents. But back in those days, there was only Part A and Part B. So once again, we managed everything. Well, personally, what happened to me, my mother had stage 4 colon cancer, survived 20 years, but when she got to the end of life situation, we all took care of her. And I recognized that because the changes that occurred with home care involved, if you didn't have somebody specifically taking care of end-of-life care, we're going to talk about what that is, then you missed out on the way we want all of us to pass and the way we want all of our relatives to pass, with dignity and comfortable. And what I found was that's what hospice did, and they did it well. So I was enlightened when my mother passed away, and that was back in 2010. So that's when I got into hospice. And I was already working for the home care company, so I just became a medical director. It's called Seven Fields. I ran the Seven Fields office for that 15-year period. And what I thought was amazing was, we called it an interdisciplinary group. It was IDG, and we met twice a week. And you talked about all the patients that were in your service. That's medicine. That's how we used to be in the hospital. I would walk in the hospital, if I had 15 patients, I would sit face to face with the charge nurse and one by one go over all 15 patients. And the nurse that was on at night left a recording to that nurse, so she knew exactly what all 15 patients did for 8 straight hours. Now they have 12-hour shifts and 18-hour shifts, and you can sleep in the place because they don't have any bodies. The point is, I got into the hospice because I saw the need for my mother. And when I got in and saw how it ran, I realized it was great, especially for the phases of death and dying. So we're going to go over all that. I just wanted to give you the history as to how I got involved. Personally, I had a brother die from alcohol, had a stroke. My father died after he broke his hip, and he ended up becoming dehydrated, and somebody mentioned dialysis. And he wouldn't have needed dialysis, but when he heard that word, he shut down. He didn't want anything done. And so he went with hospice and passed like 5 days later. And for me personally, since I have all this experience, that frustrated me that we didn't manage him the way I believe everybody deserves to be managed. So that's the snapshot of how I wanted to go over this topic with you, because right now you're probably seeing a lot of commercials on TV, comfort care, take care of your loved one and the government will pay you. As soon as you're done taking care of the patient, you'll get your money and those types of things. It's because the current skilled nursing system isn't making money anymore. It used to be a moneymaker. So now they're trying to change that whole dynamic. And in the process, my worry is, are we taking care of those stages of end of life? So that was why I wanted everybody to recognize who's taking care of your end of life care. And if you don't have anybody that you have already spoken to, after today, I hope you understand, you really need to make sure someone knows what your wishes are and what your desires are. And again, you can always change it. That's the other thing. I did it for 15 years. Easily 500 patients over that 15-year time that I took care of them, they got off hospice. Hospice is not a death sentence. It's something to keep patients comfortable. But what happens is you can go through an illness. Let's say, I can remember an open heart where the patient, after the open heart, it's called dehiscing, where the chest opened back up. And so it required a lot of care, and the family thought she was going to die, so they got hospice involved. And as it turned out, once it healed up, she was fine. She didn't need hospice. She actually was, independent again. But the point is, it's not a death sentence, and in case it is that end-of-life path, it's very good to get those services to be sure that the end of life for the person that you're taking care of, or specifically for yourself, is treated with dignity, made comfortable, and has an experience that is actually quality. Where do I get that from? Since 1990, I have taken care of, at one point, 7 convents and 2 monasteries. I'm a good old Catholic boy. And I don't know if you guys knew Dr. Potter. That's how I learned all this stuff. I was working for Suburban, and my accountant calls me and says, hey, I have a patient of mine down on McKnight Road that's selling his practice. You want to buy it? And I said, I'm already, contracted with Suburban General Hospital. And he says, well, the guy sees patients Saturday night, or Saturday all day, Tuesday night and Thursday night. And I thought, well, yeah, I can still fulfill my contract and do that. And he's the one that taught me all these things. And he shared these things with me, and he said, you go up to Vincentia Nursing Home and you tell them you want to be the medical director. And within 6 months, I was the medical director. And I learned from those experiences, and that's back in 1990 when skilled nursing was just starting out. But what I learned through that whole process is you have to have an advocate for yourself to make sure what you want happens the way you want it to happen. And don't forget your physician or your physician assistant or the nurse practitioner for that physician. You can get their services. You can have them be the person that guides that process. If you haven't heard about it, I think it started with ophthalmology, and they call them navigators. If you guys haven't heard that term, what a navigator is the healthcare system changed so much after the ACOs took over in 21 that what would happen is the doctor would see the patient, send them to the hospital, and the next thing you know, the patient was seeing another doctor. So now they have a navigator that controls all the services that their patients are going to require in the hospital. Okay? So let me go through phases. Hey, I dropped my phone. Let me go through phases of what we want to learn with end of life and what that means for the benefit of making sure you know. This thing makes a lot of noise. When I first heard all this stuff, all the new terminology kind of caught my attention because what it's for is to be able to document and manage on the computer. So when they say pre-active, active, and post-active, pre-active means that you see a decline. Active means that we're in weeks to days away. And post-active means you've passed, and now how is the family related to the circumstances, or the loved ones, or whoever you left as medical power of attorney, whoever's managing that end-of-life care. And what I found was, initially, I thought having it like cookbook wasn't the way to go. I thought you wanted to have the opportunity to interact with the family. But what I found was accepting the changes are difficult. What does that mean? When you get into an active phase, and I'll go through each one of these in a minute, but I want to go over the medications. When you get into an active phase of decline to the point where death is imminent, then the medications that you're taking, you have to look at them the way the body deals with them. If you're walking around, you're eating and you're drinking, you can maybe take 10 pills a day. But once you're not doing that any longer, and we'll talk about the pre-active phase, where you're sitting around most of the time, laying around most of the time because you've lost your energy, you just don't have that gumption any longer. A, you don't need those medications, and B, those medications can affect the pain medication and some of the other medication we want you to have to maintain comfort. But all that will be discussed with you when you get into the setting of a hospice program. That's the whole purpose. They lay out all the phases that are going to occur. They talk to you about what to expect, and then they go through the process with you. And what I found was very interesting. There was a nurse that was in charge of, say, 5 nurses. All 5 nurses had an aide, usually 2 aides, and then they also had what was called a, probably chaplain would be the best word. A chaplain. They had a case manager, which we used to call social service, and then they also had what were called companions. So if you see all that on your fingers, like 6 days a week, someone could walk in. It wouldn't be a nurse unless there were nursing needs, but the whole point was there's interaction, which is important when someone's going through the active phase of dying. You know, because if you think about, imagine right now if all of us just quit talking for a minute. If I wasn't late, I'd make us all wait a minute. A minute seems like eternity sometimes. And so imagine being in a state where you're infirm, you're in a either pre or active state of dying, and you don't see anybody or talk to anybody through the day. And that's what I thought was so special about the hospice program, because the way they design it is you're able to get an aide and they coordinate the care based on what your needs are. So if you have complete dependence, then someone's in with you every day for a few hours. You have the nurse stops by at least 2 or 3 times a week. The pastor or chaplain comes through at least once a week. You have companions depending upon the situation. If the person lives by themselves in a facility, then no one's there to take care of them. So you would have people there as a companion to spend some time through the day. And that service is special because no one intends to neglect or isolate their loved ones, or even if you just know them superficially, but you're interacting with them to the point where they're friendly with you, you're friendly with them, so you're going through those phases with them. You feel obligated to stick around. What happens is, if you communicate with the patient understands. And that's what hospice does so well. And again, guys, I don't work for hospice anymore, so I'm not like promoting any particular one. I'm just going through the fact that I've done it before, and I've had some cases in the last, actually it's about 6 weeks now, where the wishes of the patient weren't followed by the, what do they call them, executor. And there was kind of like a family, let's call it a situation. And when you see that, for me, all I see is what the patient's watching. And that's the part that I saw that was frustrating to watch, that like they all knew what the patient wanted, but they were all interacting in front of the patient who understood everything that was being said. So that's what brought it to my attention that this is not the way you want the end of life to go. You want to make sure who's ever in charge of it for you understands A, what you do want and what you don't want. Let's go over that real quick, and then I'll go over these phases again, or directly, because I haven't told you about it directly. Uh-oh, what pocket did I put it in? I'm a lefty. It's always in my left pocket. Okay, so we call them ADLs, activities of daily living. And what we find is, we'll say, sleeping, bathing, dressing, eating, we'll put mobility, bowel and bladder, important. And then when we get into the pre-active stage, let's say this person happens to be a 75-year-old male who was a truck driver. His wife passed of breast cancer, and his children don't talk to him anymore. So he's alone in the house that he built, and he doesn't want to leave it. I'm going to put leave no. This is actually a patient. All right? And what I witnessed was, this is a guy that got up, showered and shaved every day, always was doing something. Like he was fidgety, he couldn't just sit still. And when he was in my office, he couldn't sit still. So he would get up and go move some of the magazines or change the channel on the TV. He was always doing something. And my secretary even noticed that he came in and just sat there, and he didn't really do anything. And so when I brought it back to my office, what I look at is, I'll draw my table. I'm an artist. This is the stool that you stand on to get on the table. I'll put it like this. That's my exam table. And this guy used to get up, put his hand, get right up on the table. So I witnessed that he was moving more slowly. He didn't have the strength that he used to have, and he was groaning while he was moving. So what it shows is that there's a change in his ADLs. I didn't even have to ask him. So when you see that change, does the patient have to have multiple diseases that are going to lead to death because the disease in a 75-year-old has reached its end stage? Not at all. The thing that's so amazing in all my years taking care of seniors, it's not always, but there's a percentage that I've seen in my own practice, I'd say at least 30%. When a husband and wife have been together for a period of time and one of the spouse passes, the other one could be in great shape, but it's not uncommon for them to leave the world 6 weeks or 6 months. And it's remarkable because you just see a change in, like, the cognition changes. They're still competent, they can still write their checks out, they can still all those things, but they don't process what they used to process because their partner isn't there anymore. And so everything slows down. And so recognizing that is so important, because catching this at the pre-active stage and identifying this gives you an opportunity to have that interaction as a physician with the patient, but as the caregiver or the person that you're gonna say, okay, you're gonna be in charge of my end-of-life care. That's when you guys have to have a communication. You have it before if you can, but you have to trust that person. The way I relate it is, I've been doing this, like I said, for many moons. And over that period of time, what I've seen is, I remember cancer. When my mother first got cancer, she didn't want anybody to know she had cancer. You know, people they didn't talk about it. And it was amazing, because now, I'm sure you guys have seen the commercials, you know, like they're talking about it the way it should have been talked about 50 years ago to try more prevention than we could have had. That all being said, the reason I bring it up is there has to be a direct connection with the person who's going to care for you and plan out the end-of-life care. And that planning comes from knowing what you want. I've had patients that have asked me to take care of that, which I do. I've had cousins that have asked me to take care of that, and I have. But even with my own family, one of the things that happened, my mother, long story short, she smoked years ago, and she had some lung disease, and at the very end, she started to get bronchitis. And she said to me, I work Thursday nights, she said to me Thursday at 6 o'clock, I don't want to go to the hospital. I said, okay, I'll see you when I'm done with office. My sister, who lives in, where the heck does she live? Nebraska, hadn't been home in like 10 years. She walks in, sees my mother like that, takes her to the hospital, they intubate her. And she didn't want any of that. And I was the person to take care of and be responsible for her end-of-life care. And it's it's so devastating to feel that you let your mother down. And it was just unbelievable because once you put the tube in, you can't take the tube out. And so her end of life was horrific because what you can do is stop the ventilator. So we didn't put the air in and out. She lived for 7 days off the ventilator. And we kept her comfortable with medication, but that's no way to end your life. You know, you want to be able to still talk, you want to still be able to listen, you want to hear stories. That's what I find with patients and family. Like, I know I'm dying, but, you know, don't act like I have something wrong with me. Talk to me, you know? Did you see such and so on the news? Did the Steelers win? You know, that kind of stuff. They're still alive. They're just going through a phase where everything is slowing down. And as that phase of everything slowing down occurs, you want to have somebody that's going to be able to help you manage that. And like I said, I mismanaged my mother's death from I didn't, hindsight, because I was in charge, I should have called all my brothers and sisters right then. That's where I made the mistake. If right then I would have said, hey, just spoke to mom, she doesn't want to leave the house, she's staying put, and we're gonna let her die on the couch if she wants to. So hindsight, that was me. But my frustration was, my sister wasn't home for 10 years, and all of a sudden, that day she walks in. But the way it all worked out for me was another one of those things that gets etched in your mind. My younger brother, he was 59, drank too much, couldn't stop it despite all the things that we all tried, and he had a stroke. And I was down at AGH, he was my patient, and I went up to say goodbye to him, and he grabbed my hand, and he said, get me home. And I thought, I think I know where he's coming from, but I'm not sure, so we talked. And he just said, I don't want to die in the hospital. I know I had a stroke. I know all these things that everybody keeps talking, that they don't realize he hears every word and understands everything. They think because he has a stroke, he doesn't understand. So he wasn't supposed to drink. He wasn't supposed to smoke. Long story short, I had a key. It was a Tuesday morning. I opened the door. His girlfriend was on one shoulder. His dog was laying on the other side. The ashtray was full of cigarettes, and there was a bunch of beer cans. And so I went over to just make sure he was alive, and he was breathing. But we'll talk about end of life, the breathing changes. It's called change Stokes, where you'll take a breath and then you don't take a breath for a period of time. And so I knew what was happening. So I called my sister, and she freaked out and said, well, you gotta get the priest, you gotta get a priest. So at the time, Father Dennis, who was at the Bellevue Church, Assumption, he owed me a favor. So he went up, gave him last rites, and he passed like 6 o'clock that night. I saw him about 7 o'clock in the morning. And I felt like, at least I did that one right. Like I missed my mother's, but I got that one right. And so I felt like, okay, now everything should be perfect. So then my father falls, breaks his hip. He ends up dehydrated, and he heard dialysis like I was telling you. And what I tried to tell him was, no, all we need is IV. But once he heard dialysis, he wanted everything to stop. Again, that's why you need someone to help manage end of life, because if you have that person, and the word is navigator, remember that. You have a navigator for your end of life care. And this person will be the one that the doctor would speak to, and they make all the decisions with you. And once you're not able to make them, you have to have that heart-to-heart talk with whoever this happens to be. They have to know what you want and know what you don't want. And in this case with my father, same thing, just like I said, I should have called my brothers and sisters when my mother said what she said. When my father said the word to me, I was rounded. Like, you don't need dialysis. That's all I said, like one of those. I should have brought the urologist in, sat him beside the bed, and made sure that he understood that if we give you fluids, everything's gonna be fine. It turned out he had a urinary tract infection. It's not funny, but what happened, my son, who's a doctor today, He was working for me because it was in the summer. And he comes running in my office. He grabs a bottle of antibiotic. He grabs a bag of IV fluids, and he starts running out the door. I said, "Where are you going?" And he says, "You can't let him die because of a urinary tract infection and he only needs IV fluids. I'm going to die." I said, "You can't. You can't run into that hospital and give that." I said, "It's a nice try." And I said, "And he's allowed to make this decision. So talk to him and see if he really understands dialysis." And we already told my son, he just wanted to go see my mother. He had hit that point. He had a ruptured aneurysm, open heart. He didn't say that to me, but he told that to my son. So once again, I got like half credit for that one. But my whole point was, I do this as my job. And the 3 people I was involved with didn't really go well. My brother wasn't bad, but he still had the stroke. So again, understand what you want is important. Now, what happens is they call it a pulse is the terminology. These are guidelines. Your navigator I can't spell, so I'm going to scribble. That's navigator, okay? And this is, again, end of life care. Why do you want that person? You could be of sound mind. You could be writing your checkbook, balancing your checkbook, buying your groceries. I know people that even drove for more than they should have. But you need that person to understand. So you pick the person that you know that understands who you are, how you are, what you feel, why you feel it, and you let them know what you want. Now, how do we come up with it? We come up with, do you want CPR? Do you want chest compressions? Do you want the defibrillator? Answer? If someone comes to you and asks you all these questions and tells you to fill out the form and they don't explain each one of them to you, they're just trying to get their job done because they have to get you to fill out the form. You have to understand these are all treatment options for various diseases, okay? My mother's an example. They intubated her in the emergency room. They have what they call BiPAP. It's a machine that fits over your nose and face, and it works like a ventilator. It forces the air in. So there were things that could have been done. But once again, I screwed up and didn't tell everybody, and I wasn't physically there to make sure that it went the way I knew she wanted it to go. So again, the navigator needs to know, what are your thoughts? And I'm not trying to put thoughts in your mind, but I base it on the level of illness. My Uncle Jack is a great case. He's up on the hill. He's 92 years old. When he was 84, my father, my brother, my sister, and I walked away saying, turn it off. He had, it's called augmentation. When the anterior wall of your heart becomes effective, you don't have a squeeze. So what they do is they pass a catheter up into your aorta, and it blows up so that when the heart squeezes, for that one squeeze, no blood goes to the legs. It gets stopped where the augmenter is. And what that does is lets the muscle of the heart get as strong as it can be. Well, he was on, it was probably about 10 days. So we were all at the bedside, came back from church, we all went there, we're all looking at him. He's on a ventilator, he's on all this stuff. And we thought, he never married, had a job, you know, all the good things in life. And we're thinking to ourselves, this isn't the way he'd want to live. And so we all made the decision, let's go tell the doctor that, you know, we're gonna make him, it's called DNR. Do not resuscitate, okay? So we were walking out of the room, And the cardiologist, I don't know if you guys knew Dr. Gavis, Denny Gavis. So as I'm walking out, he's coming in. Matt, how you doing? I said, good. I said, come on in, we want to talk. Comes in, and we start talking to him. And he said, just step out a minute, and then I'll invite you back in. So he did what he did to make certain that the muscle of the heart was indeed improving. And he came out, like I said, this was a Sunday. And he said, you know what, guys, I see what you're all feeling. Give me till Wednesday dinner time. He was extubated, and he was off the machine. And so the point is, this is a loved one that we respect and felt that he reached that point, and the physician added information that changed our mind. Again, that's what your navigator has to do. And the question that the navigator asks is, what would you do if it's your mother? Or what would you do if it's your father? And trust me, I get that said to me, asked by patients or family members, and so do the specialists. So it's not like they haven't heard it. So you make sure your navigator knows what you want, what you don't want, and then make sure they know, get the information from the doctor. Don't make a decision based on what some nurse told you. Not that I'm ripping on nurses, but you want to hear from the doctor that's managing the case what they think. And if you see they're still on the fence, let's say it's Dr. Smith, we pull a name out of the hat. Dr. Smith, what would you do if it was your mother? And they'll tell you what to do. So those are the guiding tools for the navigator, but make sure that navigator knows what you want. And the navigator needs to be able to express to you if, and this is what we usually say, okay? If low percentage or doubt that I will be independent again, I'm gonna write it on this. I, like this, means independent. So you're not gonna have your independence. You may be in a nursing home, depending on what you have. Stroke is high there nowadays. Heart attack is high. We'll say illness, Parkinson's disease, MS, ALS, these are musculoskeletal. Bad diabetes, bad dementia. These are all things that you want to talk about, especially if you have any of those. And even if you have none of those, what you want to make sure your navigator understands is, what are my chances of getting back to where I was before I went into the hospital? And all that, as we're going to go through the pre-active stage, we all note it, but the patients have a good way of hiding it from you. And so what you have to do is know that person that you're going to have become your navigator so that they know you as well. Because like I said, we can see the activities of daily living change. And when they change, that's the first sign that we're getting that decline. And like I said, it can happen in someone that's well. Their wife passes and the guy doesn't have any medicines he's taking, he's doing fine. He's not there in 6 months because he loses his partner of all those years, and he just gets depressed. And no matter what you try, I put patients on medicines before. Once that will to live is gone, you can't stop it. So again, what I want to do, we'll come back to this, but what I want to make sure is everybody understands the pre-active phase slower, non-conversation. What does that mean? They'll answer any question you have, but they're not going to talk, especially if they want some more social life that was always talking. You'll see, you'll know right away because they stopped that kind of thing. If it's somebody that wasn't really a talker, but if you ask them a question, they would answer you, you'll see the answers are shortened and they're much slower with their response. And it's not from a stroke, it's just from the melancholy of either the disease, a loss of a loved one or spouse, whatever has brought them to that point. And again, the things we listed, Those are also diagnoses that you get to get into the hospice, and we'll talk about that later. All right, ADL changes, insomnia. And again, if you have insomnia, then it's not the sign that you look for. But if a person usually had no problem sleeping and now they can't sleep, that's one of the signs, okay? And then decreased appetite is big. And with that comes weakness. You want to catch this in the pre-active phase with your navigator. And hopefully the person that you designate knows you well enough that they can even pick this out. And once that is seen, make a decision now with the navigator. And I'm recommending it, guys, and I don't work for any of them. And you have one here. I think on campus you guys have a hospice that you use. So they're already, I mean, everything's here. I would definitely make sure the navigator knows that once you hit the point of eligibility for hospice or palliative care. What's palliative care? Palliative care is care provided to you because of some type of process that has left you infirmed. What does that mean? You have trouble with your ADLs. You used to cook, clean, dress yourself, bathe yourself, had no problem getting your shopping done, going to the store, or you'd have someone buy it for you and bring it back in, or you would just go have your meals here, all those things. Or let's say you noticed all that coming even beforehand and you went up to the assisted living. And at the assisted living, everybody's noticing those changes. And so what you want to have is the person that you're going to designate as your navigator, you make sure that that person knows what you want and knows what you don't want. And at this point, when these changes are occurring, that's the time to look into support. Here you have a lot of support already. I'm just putting it out there because as independent as you are, when that independence changes, a lot of times it happens quick. I tell patients it's like when you have if anybody's been to the hospital, especially recently, you're on a stretcher and you're looking up, all you see is the ceiling, and then heads pop in front of you and tell you things. And they say it so fast you can't understand it. So you're in limbo. That's what you need the navigator for. And they don't necessarily have to be there. Like they don't physically, if you go in at 1 o'clock in the morning with chest pain, your navigator doesn't have to be there. You just list that person, that they're the person, you talk about my medical problems, and they will have a conversation. But the key is, whenever the ADLs change and when the independence is questioned, that's the pre-active phase of what we call end of life. Now, what does that entail? Time period, months to weeks. What does that mean? That means that the assessment that they do, they talk about what's the prognosis. What does that mean? That means, given all the circumstances that the patient's in right now, the prognosis is, say, within 6 months. What does that mean? That means that with what we've seen, with all these changes, that we feel that within a 6-month period, we're going to see a further decline that could lead to the demise. That's hospice. If it's more than 6 months, that's palliative care. But with palliative care, you have to have something they're helping you with. So say you have Parkinson's disease and now you can't get around like you used to, you can get palliative care services. Say you've always managed your diabetes, you gave yourself shots, you took your insulin, you did your sliding scales, now you can't do that any longer. That can be palliative care. All those things that you see are changing, you just bring to your navigator. And then the navigator, especially on campus here, all you gotta do is make that phone call. And I think they're all attached. So you get to home care, you make the phone call, or you guys just call what's her face. I shouldn't say it that way, she helps me so much. Don't give me her name, I'll tell you before we're done here, because it'll hit me. But anyhow, the process of change that you're seeing, you need to let your navigator know, and then you get whatever one that falls into as service to assist you with the end-of-life care. It's so important, guys, and I'll go through the reason for that. Does everybody understand what I'm relaying? All right, so here's how I remember it. Number one, pain. Dyspnea means shortness of breath. Anxiety. Am I spelling that right? Probably not. This is restlessness. Sleep, so insomnia. Constipation is big. Fever is big. So we're talking about end of life, months to weeks. This is probably palliative care, but remember they use the 6 months. If they think in 6 months there's a chance of decline, they want you on the hospice. If not, you go with the palliative care. And once again, guys, this isn't something that we just pull out of the sky. You will recognize in the patient these changes. You just have to look for them. And none of us are really taught or have been exposed to, and that's why I'm going through it. Because, especially like I said, the basics, like if someone you ate dinner with and they usually ate a whole plate of food, and now they're not even finishing half a plate of food, well, that's a change in the appetite for sure. If they were the ones that got up and started walking right away, and now they're slower to get up and they're not moving as fast, those are the things that you see. They're obvious to you if you know that person. That's why the navigator has to know you. But please, that's why I'm getting emphasized to everybody. Talk to your navigator. You got to trust that person, and you got to talk to them. You have to tell them how you feel. You have to make the end of life as best it can be for yourself. And the way you get that is being honest and open to your navigator. And like I said, that is telling them everything you don't want, but recognizing again, talk to the doctor. Like, okay, we'll say you're married. Okay, Mary, I understand. If you have a stroke, if you have a heart attack, if you have, a broken joint that they can't fix because you're too old, or your heart's bad, or your kidneys failed, or your liver failed, or you have a GI bleed and they can't do the surgery. All those things are tough situations, but we're going to talk to the doc to see what they think the prognosis is. And as we get that data, I know what you don't want. And you have to tell them exactly what you don't want. And like I said, I screwed it up with my mother. It's easy to screw it up. I did. That's why you want to make sure whoever you're relying on to do this for you, they have to know who you are, how you are, what you want, what you don't want. And again, guided by the acuteness, okay? So the illness, whatever happens, let's say again, it's a stroke. So you have a stroke, you can't move the whole one side of your body, so what does that mean? For you here, you're up on the hill. No one wants to go up on the hill. So what do you want, what don't you want? Make sure the navigator knows. And ultimately, I tell the story, I won't name names, but this person's, I was taking care of his father. And this person, he was a judge. And his father kept getting pneumonia. He was a smoker. And when he ate, he aspirated. And so we had a little discussion. And he didn't want anything heroic. And he filled out, he didn't want CPR and chest compressions. And long story short, he finally said to me, this is ridiculous. He's getting pneumonia 6 times last year. What are we going to do? And I said, put a feeding tube in. And he looked at me like I was crazy. Like, what? I told you he didn't want anything heroic. I said, you don't want him coughing, you don't want him going to the hospital, you don't want him to have pneumonia, put a feeding tube in. He lived 8 years. And the son came in every Sunday with him and took him to mass and brought him back up and spent the day with him, took him out. He could still talk, he could still communicate, he was doing fine. And that's why you have to talk to the doc. Your navigator has to speak. There's always ways to do things. And again, when I first said it, He actually took me out to Rico's with 5 other judges. And he said to me, you convince us that my father needs a feeding tube. I said, that's easy. One of these pneumonias, he's gonna die. You put the feeding tube in, nothing's gonna go in his lungs and he'll live. And that's what you have to have, is a relationship with your navigator and speak to the doctor. Make sure the doctor, none of us will step away from communication. You know, if someone that we've never met comes in and wants to know, we're saying Mary, you know, Doc, what did Mary ever tell you? What does she want? What does she want? And if your doctor knows you, they're gonna know what you want, what you don't want. And then the navigator needs to understand that as well. Okay, everybody understand? If we're over that 6 months where we're going hospice, or under the 6 months, these things are vitally important. With that, I already briefly touched on, let's say your medications, I'll use my truck driver. Okay, let's say your medications, 3 blood pressure medicines, he had a heart attack, so he was on a blood thinner. He had gout, so he was taking allopurinol. He also had diabetes, so he was on insulin and metformin. With that, he had gastroparesis, and he was on a medicine called Reglan. He couldn't sleep, so he was on melatonin. All right, so what happens is he gave up, is how I would have to describe it. And his daughter was very frustrated. That's why I say make sure that your navigator knows who you are, what you're thinking, what you want. And tell them, hey, when I get to a point, if I say to you, I don't want to do anything anymore, then I don't want to do anything anymore. You know, because I've had family members say, well, can't you give them something to stimulate their appetite? Sure. You know, we use various things, one of which is Marinol, which is essentially the THC in marijuana, and it does give you that appetite. But it's a temporary fix, you know, and that's what, and we don't say that to the patient because they want it, we provide it, but you talk to your navigator. You know, if you want to do everything you can for as long as you can, then that's what you do. But if you get to a point where you tell your navigator what you're thinking. Okay, so again, it's very important. Pain has to be controlled. And we have what are called patches that give the medicine over 24 hours, so you don't have that up and down. You also have synthetic opiates. Tramadol is the one that's common. We used a lot of that when I was medical director. What happens as you go through this months to week phase, which is pre-active, as you start to see more of the decline, that's when we stop medications, okay? Initially, when you come on, everything you're taking, because they have to get to know you, we have to get to know you. So you come on service, and for a few weeks, everybody, and we talk about you twice a week, so everybody's going over, we'll call Mary Smith. So everybody's saying that Mary's declining, she's not eating, her skin's breaking down, you know, different things like that. And so that's when you make the decisions of, okay, let's stop some medications because we're going through a change. That way these medicines will work better. You know, the blood pressure, because they're not doing anything, we don't need 3 medicines anyhow anymore. So that's when the changes occur with the medications. You control the pain. It's what's called sublingual morphine. It comes with an eyedropper and a bottle, and your navigator, if they stay with you, can be trained to do it. If not, the nurses do it as needed, and that goes under your tongue to get rid of the pain. What unfortunately happens is pain medicine slows down the colon, and that's where we get into the constipation. So as soon as you start the pain medicine, you have to start a stool softener. You know, but once again, that's why I say these are things that the hospice people know, and they're very good at it. And I'm sure the one here, I don't remember the name, but I'm sure the same thing. What happens with dyspnea, opiates slow down the respiratory rate. Does that mean that we don't give the opiates because we don't want them to have respiratory troubles? Not at all. All is required is usually a liter of oxygen. So you get the cannula in the nose, you get the oxygen on, takes care of it. They do what's called a pulse ox. And that's what keeps us aware that lungs are working well. We go up with the oxygen as needed. Generally, we don't have problems with it unless you have underlying lung disease, and then we treat you just like your doctor would. You can get breathing treatments, you can get medications, steroids if you need them. So you're managed medically. That was what my job was. When these new patients came to us on service, I managed their care. Okay, so that's all taken care of. Anxiety comes in many flavors. Okay, that's why I circle the restlessness with it. Everybody's different. Some people like to talk when they're in that pre-active state. Other people don't like to say anything. Most people get them to talk about what they're thinking, and that's sometimes when you see the anxiety present itself. And once again, those medicines are given sublingual, and you always offer a trial. You know, so you talk to the patient, the nurses would call me up and say, "Doc, I talked to Mary Smith. You know, she's getting a little anxious now because you had to get up on the oxygen. She's worried something's going to happen and she's going to be by herself." I said, "Okay, so make sure the companion's with her." You know, we adapt based on what the symptoms are. But once again, that's why I put it, this is very, very important. These two, the anxiety can cause the restlessness and back and forth. And the medications that are used, we take care of. Now, one of the other things with the S is what we call secretions. Once you start taking these medications, what can happen is you can't swallow as well as you could before. And so you don't clear the throat completely when you swallow. And so sometimes you'll drool, and that extra secretion we dry up with a medicine called scopolamine. It's a patch we put behind the ear, and that can be managed so there's not a problem. That's why I bring up in terms of the pre and that part of coming to an active state. You get a team involved, they get to know you. It's pretty remarkable. Like I said, I did it for 15 years and it was very moving. You know, I mean, you had a lot of great cases. The girls would come back and tell you stories. You know, I saw Mary today and, you know, she said she wanted to crochet. When I talked to her, she hadn't crocheted in 20 years. But it was something she wanted to do again. So she showed her where all that stuff was for her to try to crochet again. So again, the guy, for me, when you're in this state and your doctor can guide you through that, if you're greater than 6 months, palliative. If not, you get the hospice in. These are the things that are paid attention to. And when I say daily, someone's there daily. Once you get signed on to a hospice program, there's daily contact. Now, they don't stay 24 hours a day, but based on your needs, like I said earlier, if there's a skin breakdown, then there's even a wound nurse that comes out. And of course, they try to prevent that from turning the patient side by side, okay? Active. Breathing changes. You'll get I'll do it like this, a good breath, followed by a little breath, and then no breath, and then a good breath, little breath, no breath. That's called change Stokes. And what happens is the oxygen in, they'll still stay with the pulse ox over 90, but that's showing you that the body's starting to slow down from the neurological standpoint. And as you see that, you're going to see changes. The skin is what we call mottled, where it'll either turn very white or sometimes like a purple hue. And then we see things that a lot of times on the nose or on the earlobe, you'll see that the changes that occur, instead of it being plump, it'll start to get thin. And sometimes in the tip of the nose, you'll see a little crease. And that's just all related to the breathing itself. So when they take the breath, it's a little deeper, and that's what causes the changes. It's all cartilage, okay? So these are the signs that being in hospice, we're all well aware of. Your navigator just needs to communicate, meaning they don't need to stay with you every day, every moment of every day, but if anybody that's around you other than the team sees any changes, you alert the team. Once again, guys, you have no problem because you're here, and everybody communicates. Desiree, told you I'd remember her name. You know, so what happens is you have that case called Desiree. She gets hold of the doc. everything takes care of, it works. But again, make sure whoever your navigator is communicates, knows what you want, and they communicate. All right, so we see the breathing changes. You'll see behavior changes. Sometimes comical, sometimes, let's say, agitated, and then in between. And like I said, I did it for 15 years, and it's, I laughed. You guys remember Batman? The Joker's father was my patient at Manor Care, okay? And he was on hospice, and he'd be out in a wheelchair. They'd put him out in a wheelchair in the front of where the nurse's desk was. And so there'd be a visitor come in, you know? And when the visitor would come in, this one day, this guy comes in, and his mother comes over, and the guy tells the mother a story about how he needs to, I think it was some money or something or whatever. And again, this guy, after that incident, he left the world like 7 days later. He was definitely in a decline, unfortunately had lung cancer. But as the son's leaving, he starts telling her, he's lying to you. He just wants your money. Don't give him any money. And this guy never talked like that ever before. And that's my point. You'll see changes in their way they communicate and the things they say and do, which is completely different. Not all the time. Probably the majority of the time they're the same person. But my point is, these are when you notice these are active signs of a decline. You'll see the heart rate change. Usually it gets slower. That's when you can have trouble with the bowels. Same thing, slows down. And that's when you might have to add like a stimulating. The one we use a lot of is called Miralax. It's hard to push the water because of the swallowing trouble, so we usually get a humidifier, so that at least keeps, the mucous membranes moist just from the humidification of the air. And then from the active state, we get into post-active. That's where your navigator comes in. If there's been communication through the process, the whole team shows up. So everybody that has met, again, we're going to call her Mary Smith. So everybody that has met Mary Smith, they do their best to get as many people out as they can because they have had a relationship with the family or the navigator during that time period. And they all want to come to make sure that it went the way we all planned. And then they always look for, whatever critique, because it helps them if they find something that they weren't happy with, and that's something that they change. But the point to it all is, please make sure who you pick as a navigator communicates, because that's the most important thing, is having a direct conversation. And the nurses do a good job. So like I said, twice a week we met as a group. It was an interdisciplinary group. They called it IDG. We had 2 IDG meetings a week, and you went over all the patients individually. And everybody talked about it. The pastor, the aide, the nurse, physical therapist, all those people that were involved spoke about the patient every time. That's why I promote it now, because I've not only worked it, but I see this whole process of end of life. It's so important, and we're neglecting it. And I told you, knowing what I know, as I'm telling you now, I've known this for 20 years, and I still wasn't there for my mother. Hindsight. Like I said, if I'd have called my brothers and sisters, it would have never happened, because I knew what she wanted. Communicate. Vitally important. Okay? The last thing I leave you with is, because it's the most important, guys. Whoever this person is, you have to trust. Tell, and I'm calling it the navigator, what you think. Our service was big, so I didn't get to see everybody. I saw most people that were in nursing homes and assisted living and places like that, because it was simple. But getting out to the homes, it was just something I couldn't do, but my nurse practitioners did. And a lot of times we did Zoom. And I would stop and see as many people as I could. And what I always tried to do was have a conversation with the patient and develop an understanding that we could talk about anything you want to talk about at any time. So please have that same relationship with whoever you pick as the navigator. Because that's why I say, what are you thinking? That's such a, if you trust that person well enough, talk about that now, because you're all good, and make sure that person asks you that. What are you thinking? Because I used to love that. Great answers, great answers. It's wild. You know, it's everybody death and dying, we don't even talk about it anymore. And that's why it's so amazing. Everybody assumes you walk in, the person's quiet, they're not saying anything. People even get quiet and whisper. You know, it's just like no one knows how to act about it. It's like the exact opposite. I just spent the weekend with my grandson, and everybody, you know, like you watch them and you laugh. Like they'll start making goofy sounds and crazy faces just to try to get the baby to laugh. And it's unfortunate at this end, people walk in, and if no one's talking, they don't say anything, they just sit down. You know, go up and talk, have conversation. And that's the best thing to say. What are you thinking? Tell me what you're thinking. And like I said, it drives conversation, and a lot of times as people are talking to you, they'll tell you some things, maybe they're afraid of something, or maybe they're having pain they didn't tell somebody about. But either way, it's very important, guys. My hope is that if you think you have any issues, there's a hotline. It's the American, I don't even have to put that up for you guys because you have it all here. But if you know of other people and you want to share that with them, it's the American Home Care Association. And it's a 1-800 number, Google it, you can find it. And that's how you get them involved to get to you. And again, there's a intake, they call it, where they come out, talk to you to see where you fit in. A lot of times, hospice goes out, and then they'll say, Doc, you know, patient's not less than 6 months. She's actually doing okay. I think if we fix the wound, or I think if we help her with, say she just had pneumonia or something like that, she'll do pretty well. So then you go palliative. So all those things, though, are built in. All you gotta do is make the referral, and you have it all here, so you have nothing to worry about. But even here, with them around and knowing and communicating with you, you gotta tell somebody everything you're thinking. And hopefully you have someone close enough you can do that with, so that they know this is what you want, this is what you don't want. And I'm gonna talk to the doctor, because if the doctor says that, yeah, she just had a pretty big heart attack, but you know, she's pretty strong, you know, let's give it a couple days, something like that. You know, you don't instantly know details where the outcome is gonna be. Those you give time to, you know, but otherwise communicate. Okay, everybody with me? I hope it was beneficial to understand that, again, guys, things changed. Used to be, like I said, when I first started, people stayed in the hospital the whole time. In fact, it was bad. That's why I accepted managed care. I can remember doctors that smoked, and they'd admit the patient with COPD, and then on Friday, they'd let them go home, and then they'd readmit them on Monday. And so I bought into the fact that, all right, maybe Medicare is getting ripped off, all right, maybe this managed care is okay. Wrong, but that's who knows time. Good, any questions, guys? Good, sorry I was late. Thanks for having me. I have this.